So good afternoon. I am very delighted to introduce Dr. Lardier, who is an associate professor in our department. He's a developmental psychologist and an LPCC, and has over a decade of experience of providing psychotherapy to adolescents and adults with co-occurring mental health and substance use concerns. He uses a strength-based, free motivational approaches, and he supports training for providers across the state and nationally. And he currently provides services through our athletic department, the faculty clinic, and the IHS. And then has been working on this community engaged service delivery and implementation science research focus with the across the state with school districts. So he's received funding by NIH, SAMHSA, and other agencies, and his work is on multi-level prevention, intervention, and systems change. I know many of you had the chance to learn from Dr. Lardier, and I'm excited to hear his presentation. Thank you.
Thanks a lot, Dr. Bonham. Thank you, everyone, for joining Grand Rounds today. I'm very excited, not nervous at all, to present to you all, esteemed colleagues who I've had the opportunity to work with in various capacities. So I'm going to start sharing my screen, and then you could tell me if I messed it up. Okay, can everyone see it? Yeah, great. Perfect. So as Dr. Bonham mentioned, I've had the pleasure of being one of the lead evaluators and one of the leaders on this Project Aware initiative through the state of New Mexico. And today's presentation, we're going to talk through both the implementation of this work as well as some of the outcomes that are associated with this project. In terms of disclosures, I have no disclosures to name beyond the fact that this grant was funded by the Substance Abuse and Mental Health Services Administration to the state of New Mexico. I'd be remiss not to acknowledge the partners across the state, including, and most importantly, the local school districts who have implemented this project in Roswell, Socorro, and Santa Fe, and who are providing high quality care because of this work to youth in these districts who would otherwise not necessarily have services. And so, as I mentioned, the three learning objectives that I hope to achieve today with you all is to describe the goals and structures of this collaborative framework, to summarize the key findings from the evaluation of the Project Aware implementation in 3 New Mexico school districts I just named, and highlighting, most importantly, the successes, potentially discuss some of the challenges and some other contextual factors, and really then kind of wrapping it all up with some lessons learned from the evaluation, as well as the outcomes associated with that, to inform future school-based mental health systems, both in our state and beyond. I wouldn't be a great educator if I didn't bore you for a moment about some of the history associated with why we have behavioral health initiatives in schools. And I'm not going to sit here and read each of these points from the 1940s to 2025, but I think it's really critical to say that this work related to mental health throughout our nation started in 1946, so about 80 years ago. And after that, we focused on the expansion of services away from institutionalization into our communities in 1963, and then accelerated right from that point on to initiatives that included 504 disability rights, expanding services for children who were handicapped, and providing other services within schools. Coming straight into the 2000s, we see No Child Left Behind and some mental health provisions and grants that were funded through that. We see the expansion and creation of the School-Based Health Center Alliance, which was a foundational program for school-based health systems in school-based related health systems, and the integration of health and wellness in schools. And then as we move towards the 2010s, we see where Project Aware, the grant I'm going to talk about, comes into fruition. And it's important to mention that Project Aware was established as a result of Barack Obama's Now is the Time initiative, which was launched in the aftermath of the Sandy Hook elementary school shootings. And as I'll mention in a few moments, this was one of the largest federal funding initiatives to implementing school-related mental health services in our nation's history. As we kind of get closer into the 2020s, we see this work continuing. We see the 2022 Safer Communities Act, additional federal funding distributions from 2025. And then as we come to New Mexico, right, we see the implementation of the SB Senate Bill 3, which is focused on regional systems of care and community-driven behavioral health planning. And so I simply kind of put this overall timeline in front of you to say that, again, this work in terms of mental health is very short in relative to the nation's history, and the work that is embedded within schools is even shorter, but it's incredibly, incredibly critical, as I know each of you would agree with. And so let's dive into Project Aware. As I mentioned, Project Aware was established in 2014, a federal grant initiative designed to expand in school-based related health initiatives. I think I'm getting some feedback. The focus area here was on awareness and literacy, early identification and prevention, providing trauma-informed approaches, and increasing and expanding strong school community partnerships, right? And as I said, it represents one of the largest federal investments in school-based behavioral health infrastructure. I'm not going to sit long here again either, but just to remind us why New Mexico, why were we funded for this? We all know that New Mexico experiences disproportionately high rates of suicide, mental health rates, particularly at the time that these funding were received. We know that less than a quarter of the estimated need for mental health care in New Mexico is met by the current actual availability. And then as of March 26 of 2025, New Mexico entered into a Kevin S. settlement agreement where parties acknowledged a mutual commitment and the development of trauma-informed services and systems of care that meet the needs of New Mexico's diverse youth. And I put the wrong date there, meant to be 2020. But if you're interested in knowing more about Kevin S., I put a QR code at the bottom of the screen that you can scan and go directly to CYFD. So Project Aware is an intervention and prevention program. It's a 5-year grant initiative. We're unfortunately coming to the end of those 5 years this year. The purpose was to develop sustainable infrastructure for school-based mental health programs and to promote healthy development in school-age youth and to prevent youth violence. That latter part being specifically language related to the aftermath of the Sandy Hook shooting. And the 5 key objectives of this program were increase awareness, provide training to adults to detect and respond to mental health concerns, which focuses obviously at second point on workforce development, connect affected youth and families to services with referral and access support, establish sustainable programming and mental health support, and really through our evaluation ensure continuous quality improvement so that the work that's being conducted here is not necessarily, the data is not just coming to us and we sit with it, right? But that it's an iterative process of feeding back into the community, into the program to ensure that the work is continuing to expand, improve, right, and meet the needs of the youth based on what we see in our findings. The goal at the end of this grant was to reach 500 young people throughout these school districts. And then I can say, as you'll find out today, that as we come to the end of this project, we are right on the cusp of that. So as a New Mexico initiative, right, purpose of, as I said, Project Aware is to focus on these collaborative partnerships, increase mental health awareness and concerns in school through training, support students through both clinical direct services as well as I'll talk about peer navigation services, and then create a sustainable program with long-term impacts that extend beyond the grant. The university-state partnership is incredibly important to name, right? Because the university we've been able to provide a tremendous amount of support, not just in terms of the evaluation, but in addition to that, clinical training as well to support the delivery of services to the young people in these districts through the clinicians that are providing that care. We work very closely with our state partners as a result of that, who include the Public Education Department in New Mexico, as well as CYFD. And as I mentioned, we're on the cusp of engaging over 400 students. And this is just a graphic representation for those visual learners of that same purpose. So what did Project Aware student participants receive as a result of the intervention effectively? First and foremost, they received screening and assessment to identify immediate risks and needs. They engaged in active treatment planning and were referred as needed to psychopharmacological support in the community through a MOU with a local psychiatrist or a telehealth psychiatrist. They were provided mental health and co-occurring services, and many of those co-occurring services were done with the same therapist through referrals or alongside a peer navigator. And I want to really mention here that this work was all done again in schools, right? The therapy, all the therapy-based support services were done in schools in a specific location that was designated for Project Aware to provide that therapy. And then, as I mentioned, case management was also provided that helped students and their families navigate additional resources and system needs to ensure seamless connection to other services, right? But to augment and improve, right, their mental health outcomes, as you'll see. Because as I talked about my systems of care class this week to residents, right, we live within multiple intersecting ecological systems. And it's impossible to imagine that the individual's mental health needs are going to be improved by therapy alone. And so providing wraparound support effectively to the youth and their families was integral to the success of this program. These are some of the secondary services that were provided as like a glimpse, right, for you all to kind of get a sense, right? This included developing MOUs between medical services, potentially HIV-related care services, and STD, STI services, employment and education services and other support, family services, transportation, housing, food support, daily living services if students were unhoused, as well as childcare services for youth within these programs. And the main purpose, right, as it's written on the bottom part of this slide, is to foster empowerment, recovery, and connection, right? Because as I mentioned about the needs in New Mexico, many of the young people through this program experience, as you'll see in the latter slides, disproportionately high rates of, unfortunately, trauma that were embedded within the communities that they lived, right? And so consequently, these services and the wraparound support care were pretty instrumental, right, in ensuring to see the improvements that I'm going to show you later in mental health outcomes. The data that we collected for this grant was through what they call the National Outcomes Measures, and it's a standardized tool that is through federal legislation. It's called the Government Performance and Rating Act, GPRA. And this assessment is provided by SAMHSA to as a federal funding agency to the local entities to collect outcome data related to the project at baseline, 6 months, and discharge. And when we approach the sites with this, I will say very quickly that we focused on how do we utilize this GPRA not just simply as a tool for measuring outcomes for our purposes at UNM, at the state, and at the local level, but to include as part of the intake process, right? And that clinicians have a sort of standardized approach to their intake protocols that can be then folded into, right, the sustainability of the project, right? And that was pretty well received actually by the clinicians and the site administrators at the time. So in terms of how we received the data, students were referred to the program, and that referral could come from self-referral, I need help, I need services, family or parent-based referral, peer referrals. That could come from a school nurse, a teacher, right, a social worker within the school, a school psychologist, right, and then they would be referred to Project Aware for a clinical intake. The data were transferred to UNM through a secure system, and as the lead evaluating agency, we were tasked with not only evaluating this every quarter for the last 5 years, but providing recommending trainings based on our findings, providing trainings potentially based on our findings to improve program delivery, as well as feeding it back to the districts through presentations and reports, infographics, et cetera, to ensure that the sites also had the same information that we had on our end to do the work that they needed to do on their end. So this is just, again, like the kind of a primary purpose of and sort of the research question are how are students responding to therapy and navigation services? And you can kind of see this linear path to where we implemented and evaluated this program. So now we kind of get into the fun, or at least the part that I enjoy the most, the data, where we get to talk about what we saw over these past 5 years. And so I would say that most of the data are highly representative of what we see in our state demographics when we compare to our state and national data, at least for New Mexico. And the one thing I will say is that our Roswell, New Mexico, predominantly Hispanic and serving some Anglo and white students, Socorro, Hispanic predominantly students. But Santa Fe was a district that served only until more recently at the end of this grant, Indigenous students in the region. And I think that's incredibly important to name because it's number one, set us apart from every other federal, from other Project Aware grantees when we've presented in Washington or in other settings that were other Project Aware grantees would be located. And so we were doing unique work in that way, but also providing very specific support to students that often lack and receive less services in our state compared to other groups. And so Santa Fe also their school district's implementation of this among Indigenous students was also ran by the program manager, who also identifies as Native American, American Indian. And I think that also was incredibly critical, not in terms of just relationship building, but creating a therapeutic approach and system that spoke more to the traditional needs of these students. For example, they created a space within the program that was called the Nest, where students could simply not only interact and engage in one-on-one therapy, but also receive other additional ancillary supports that are more culturally responsive to their needs based on the discussions of when the program was built. And so you see the representation here, right? The average age was about 13, predominantly Hispanic, right? And Native American, American Indian. Most of the students we receive clinical diagnosis for, this is quite representative of what we see at least nationally. Were experienced an anxiety and or mood disorder. With, you can see a range of other diagnoses that were collected from the charts during the time this grant was implemented. Most of the students were living in a private residence. But you can see that there were a few students in various other locations. And on the right-hand side, what you'll notice is there's information on where students spent time over the past 30 days from when they took this at baseline. And you can see that some of the students in this project were also intersecting with emergency rooms, psychiatric centers. They were unhoused. Some were intersecting with the correctional facility or even detox. Very small proportion had been arrested. And I found it quite interesting that about almost 17% were unsatisfied with their living conditions. And I think like that would, for us, qualitatively be interesting to unpack a little bit, to understand a little bit more deeply. What we see here is assessment of the overall mental health outcomes associated with the project. For this, and this is a question on globally, how would you rate your overall mental health right now from a point of poor to excellent? What we see here, and I circled it for you to kind of take a glimpse, is that we see about 38% of students felt like their mental health was okay at baseline or was very good. And we saw quite an increase, about 10% towards discharge. But where we saw the most movement, right, was in like, and this again is very arbitrary in terms of like what makes something very good and good. But for us to kind of just point at, right, we see is that for those who identified very good, it was quite low at baseline, about 10.5%. But what we saw was a very a steep slope in terms of increase towards at discharge, right? And I think that this is a really important slide to kind of sit on for a moment because the results show that there are some improvements from baseline to discharge as a result of receiving the therapeutic services that were provided, as well as for many of the students, the wraparound supports. What we see here is an everyday life score. Again, it's very global, these questions that are provided by SAMHSA. So I put on the right-hand side sort of like what are the questions that are being asked, like how am I handling everyday life? I'm able to deal with unexpected events or circumstances. I get along with my friends and other people in my life. And again, this is a total score of those items. But what we see is from baseline to discharge, again, we see an increase in scores that for all intents and purposes, at least across these time points, is statistically significant, as well as meaningfully significant, particularly when we go back to this, have gone back to the sites and reported on these numbers. They've also articulated this same, they've also named the same fact when they've worked with students, is that it's been wonderful to see many of the students' improvement, but to see it in the data also provides additional validity and reliability to that experience. We're in the midst of collecting qualitative data to understand this a little bit more, so to be continued. This is a global, again, another measure that SAMHSA provides us on psychological distress. It's called the Kessler Psychological Distress Scale. The QR code's there if you would like to see any papers about it. Again, it's very global. It sort of combines both aspects of the PHQ-9 and the GAD into one short measure. And what we notice here, right, is, and it's the slope kind of is a mirror image, right, of the improvement scores, is we see a decrease from baseline to discharge, actually quite precipitously, in terms of students' feelings of distress. And again, this was also a significant change. This was important for sites in an area of work that we had to implement. I'm speaking to the choir when I say this, right? But when we started off with this grant about 5 years ago, when we talked about screening for a suicide and screening for trauma, it wasn't that this wasn't going to happen or wasn't happening. What was not happening, we noticed when we looked at the data, and this is again the iterative process of looking at the data and feeding it back to the sites in terms of what we can improve. What we noticed wasn't happening in the data is that when students were screened for suicide, safety planning wasn't following. And this was a bit jarring when we looked at the data, but it provided us something immediately to focus on when we went back to both our Ph.D. and CEUs colleagues as well as the sites to provide in terms of training so that sites could adequately understand the importance of not only screening for suicide, which is incredibly important, but also the practice of safety planning through that, right, as a result of that. In addition to that, students were screened for trauma, and that was done through the PCL-5 as an initial screening tool. And what students, what you'll notice is that about 68% of the 300 students, so about 210 at baseline, for example, screened positive for trauma, and 72% at reevaluation, and at discharge of those 221, 60%. And this was equally important because we also had to provide training on what does it mean to screen positive, not necessarily what does this mean to screen positive for trauma, but what do you do when that happens, right? What type of therapeutic interventions would be most important to provide? what modalities of treatment would be useful, what wraparound support services would be important at this point. And so there was a lot to be learned from these data when we presented them back to the sites and discussed with them some of the findings that we came up with as a result of their reports. And it was pretty remarkable on the site's end. Of course, there was nothing, they didn't say there was any inaccuracies. They sort of said like, yeah, we welcome the training because maybe this was a gap in their own individual trainings when they were in their programs, their clinical programs. In addition to the measures I just named, we also collected data on substance use. And this was actually interesting, is that about 2 to 3 years into the grant, SAMHSA said you don't have to collect any more substance use data. And we're like, well, that's interesting, given you're the Substance Abuse and Mental Health Services Administration. So what we opted to do alongside with our sites was to continue to collect these data, because what they found is that obviously, as we all would imagine, this was incredibly important information to capture and also to see in terms of trajectory of change, to feed back into the sites, both in terms of need and get an understanding of the substances that youth are using collectively across the sites. And what we notice here is that, not very different than what we see nationally, is most young people were using alcohol and cannabis. And as we all know, right, those are in our state with legalization of cannabis as well as high access to alcohol. Those are the sort of things that are easily utilized. And we see lower rates of tobacco, which again is, while accessible, is nationally, we see less use. But what we do see on the very bottom is the other, and that was mostly characterized by vaping and e-cigarettes. So nearly 20% of those young people, right, disclose vaping or using e-cigarettes, which again is a trajectory of growth that we're seeing in national data too, and a point of intervention for the clinicians when we discussed it with them. I had my team kind of look at some of the substance use data because I was sort of interested in understanding, for those students who disclosed positive use or a yes to any drug or alcohol at baseline, did we see any change at reassessment and discharge? Because if I go back to this slide very quickly, you can see the change, those bars, and those bars represent, baseline, reassessment, and discharge. What you'll notice is it looks like kids actually increased in use as a result of the project, which has a lot to do with the sampling distribution and when data is being collected. And so I really wanted to hone in on those baseline uses and see what type of change we were able to identify, if any. And I'm going to give you a small glimpse of those data for us to kind of unpack a little bit. And what we notice is that at baseline, 100% of the kids in this small subset, right, which is again about 21 to 60 young people. For alcohol, it's actually 31 at baseline. So 31 of those young people indicated drinking at baseline, and then how that changed at reassessment and discharge. And what you'll notice is that at reassessment, we saw a 60-30 split, right, which provides some indication of change. And we're not necessarily sure as whether or not that can be fully unpacked or described by the therapeutic process, but one hopes so. And at discharge, we see nearly like almost a 50-50 split. And again, context and life is happening around these young people as they are engaging in this therapeutic work. And as we know about substance use and mental health, it's definitely not a linear process. So I think like this was useful for us to feed back to the sites because again, it provides us more nuance and information concerning the trajectories of substance use within this population, but particularly alcohol use, and what clinicians might want to consider as they continue to engage in this work. This is another example of cannabis. 100% of those young people who indicated, right, use early on at baseline, and then how that changed. The one thing that was very interesting here was that the large jump at discharge to a 60-30 split opposed to the 44-55 split at reassessment. And again, this is something that we have to unpack a little bit more, but it does put into, at least it stands out to me because, again, it goes back to the fact that treatment isn't linear. We can see improvements at 6 months, but then at discharge, things may be shifting, and they could be at discharge for a number of reasons from this program. They could have not showed up. They could have simply not wished to continue services. They could have graduated and they needed to be discharged. And so also unpacking, which wasn't prepared for this presentation. We haven't actually unpacked at those results yet, but unpacking for those who use substances still at discharge, what was the reason for ending treatment? And so here's just some discharge data that, in addition to what I just kind of showed you, right? We've been feeding back to the sites as well, like the length of time they're in treatment. And I want to remind everyone that these services are provided all year round. So even when the school districts end their educational programming, Project Aware's initiative continues throughout the summer for those particularly for those students with a high acuity or high need and who would otherwise not have access to services. So on the average, about students are engaging in services for about 6 months. And we've had some students seen in clinic multiple times. So about 60%, about 37% of the students who have been engaged in Project Aware were seen more than once, right? So we collect those data as well. And that sort of numbers are accounted for when we do these analyses, right? We don't repeat that information multiple times. And here's some additional outcomes data, right? And this is part of what has made this project incredibly successful is throughout this project, there's been over 1,400 referrals generated. And while we've only engaged 400 youth, these referrals include students who are maybe not engaged in therapeutic services, but engaged in peer wraparound services. And so these numbers also include the students that are engaged by the peer support worker. And so over these near 5 years, 1,439 students have been referred to everything, both mental health and ancillary service related, externally and internally. And what we notice is about 1,100 of those received access to those. And the sites have been very good about following up on those referrals, ensuring that the students who are referred follow up or are able to access. And so about 78% of those students. And the reason that this number is so high and this has been so successful is because of the peer navigators in these sites. This number would not be possible without those individuals who are often individuals with lived experience, often have a bachelor's degree or only a high school diploma, and are there because they want to support young people and the services that they need in this local community that they're most often from. And so there's an incredible vested interest, of course, to seeing the success here. These are some of the other indicators that we collect as a result of this project. And SAMHSA calls them IPP indicators, so infrastructure, prevention, and promotion. And so over the course of this project, we have tracked policy changes. So for example, over the past 5 years, 22 policies have been implemented in the schools related to mental health across the districts, whether that's a policy focusing on safety planning and suicide and trauma screening within the clinic, and that is a district policy, universal screening. They've also implemented policies to, if there's a crisis on the campus, how do they then roll out the services that are needed through Project Aware and their support system? So there's been a lot of different policies that have been implemented as a result of this project. We've also trained people specifically to workforce development. Over 300 individuals have been trained. The number of organizations that have been formally written into MOUs or MOAs is about 12. The number of individuals who have received training on prevention and promotion, this was pretty astonishing. 2,163 people were trained on prevention and mental health promotion training throughout the state as a result of this initiative, which means that individuals, that there are many more individuals who now had access to additional training opportunities and often CEUs as a result of that. And this is the last one is a number based on the percent of individuals who demonstrated improvement in knowledge and attitudes related to those trainings. And it varies, but on average, what we notice is there's a 60% knowledge change. We measure that right through a pre and post test during the training, but it ranges between about 45% to 98%. As I mentioned, the peer navigators are, effectively part of the bread and butter of this initiative. That this group of individuals, when we've presented in Washington, or I've had the opportunity to more recently present at another conference called Suplin, focus on university partnerships, people are very fascinated and interested in knowing about these peers, these navigators. Because they often aren't considered when both implementing a grant period concerning mental health, but often are not considered and utilized within school districts. And what we see here is that over 1,000 individual families and children, students have been engaged in services through peer navigation. And in just fiscal year 5 alone, we see over 170 students and their families being able to receive these services, and the peers spending anywhere between about a 0.3 of an hour to 2 hours. And so as I come to sort of the conclusion of this presentation and think about I'm going to present here what I've kind of learned as a result of this project. And this might be clear to you already, but I think one of the things I've been trumpeting is that schools are an effective access point for behavioral health care. And in the way that Project Aware does it is unique because they function as very similar to that of a sort of a private practice in a community, meaning they're embedded within the schools. They are working alongside teachers and staff and and administrators. And yet they function in all the districts that we've worked in, they function somewhat autonomously, right? To ensure that student records within these clinics are maintained separately from the student records of the academic institution. So the great HIPAA-FERPA divide. But because they're embedded in schools, there's the ability to ensure students are screened, assessed, and engaged directly within the school, meaning that there's no gaps or lapses in service referral to services. And as a result of that, being embedded in schools, what we've also heard anecdotally is that it lowers the stigma in terms of entry point because students see these services, they walk past these therapists, they see the clinical setting, and it's not something that's necessarily taboo or strange to imagine a student seeing. And so the other thing that we've also learned from this is that cross-sector partnerships are essential, meaning in order to sustain the impact of this initiative or initiatives like it, collaboration is needed across education agencies, both at the state and local levels, behavioral health providers, both within the school and in the local areas that they're being served. Universities have to be, in a way, a part of this to help facilitate and support those services, and between the state entities and the local areas, because there's often a very strong disconnect. And the state systems have to work very close, are forced in a way to work very close and in tandem with their partners on the ground, which I think engenders also trust for local districts that often see these state entities as very far away or not necessarily understanding their needs. And so I think the partnership between Ph.D, CYFD, and our local entities actually was enhanced because these individuals from these state agencies were on the ground, seeing the work that's happening and working incredibly close over these 5 years with these local education areas. Workforce expansion, particularly related to this project, must include, I think, non-traditional roles to facilitate referral and access. As I've mentioned several times today, peer navigators and community embedded staff are highly needed to enhance engagement, referral, follow through, and importantly, cultural responsiveness. The the effect that the impact that we've been seeing in Santa Fe, because the program is focused on Indigenous students, ran by an Indigenous or Native American Indian therapist, and incorporates the knowledge and traditions within the therapeutic work, has made it incredibly, the outcomes have been incredibly positive because of that. Not only in relation to mental health outcomes, but we've also been able to collect kind of parallel those data, the mental health data, with education outcomes, wherein many of the students who are receiving care in that program who were having concerns in school or doing poorly have seen a shift in their success academically at their school in Santa Fe. And so consequently, it's also improving many of the other areas and domains of their life as well, alongside their mental health needs. Flexible staffing models to address workforce shortages in these areas that have high need. And I think as I mentioned, the high referral and access rates highlight the importance of these navigation support services to ensure students receive the care that's absolutely necessary. Behavioral health, as you all know, improves services over time. These sort of longer treatment periods and ensuring that programs in schools are funded at a level where they can continue throughout the summer are meaningful to seeing clinical change, as we all know who provide clinical therapeutic support. It cannot end when the school semester ends and needs to find a way to continue in any way it can. And I think this program has been a great example of why that's so important. Collecting real-time data and feeding that back into the system, as we can imagine, is also useful towards clinical decision-making, improving capacity, right? Clinical capacity and treatment, as well as ensuring that the work is sustained, right? Because you can argue and provide evidence to prioritize funding. As a policy nerd, I would be remiss if I didn't say that these programs need to align with policies need to align with the program's outcomes and short-term grants to catalyze change. And it needs to integrate, and education and behavioral health policy need to be more integrated, particularly within schools, because there is this HIPAA-FERPA divide that often creates a lot of barriers to care that students and the clinical staff and the school administrative staff often find difficult to navigate, and don't often consider at the start of kind of building programs like this. And so the bottom line, after this 45 minutes you've been listening to me, I could have just sat on this slide and just said this, is that Project Aware New Mexico demonstrates that school-based behavioral health works best when it is collaborative, data-driven, trauma-informed, and equity-centered, principles that are transferable across New Mexico and nationally. And so I want to just thank, my collaborators here at UNM, Dr. Chavez, Dr. Malusian, Carolina, Anna, Sandra, who are all students and staff on this project, our CBH staff, Tara, Beth, Maddie, and our collaborators at Ph.D. and CYFD, Magdalena and Michaela and Danica and Gustavo. It's been a tremendous 5 years, and it's been a pleasure to present the successes of this program. And so with about 15 minutes left, which is what they asked me to do, I can't believe I'm on time. I'll take any questions or comments or thoughts. I see a hand by Avi.
Hi, Dave. Wonderful. wonderful presentation. I was wondering, you didn't mention school-based health centers, and I know that you're very familiar with that. How important do you think that infrastructure is in executing this kind of program? And then you talked about sustainability. What's your hope and what's your predictability as far as what's going to happen when the funding ends for Project Aware, specifically about peer navigation and a lot of these so-called ancillary services?
Yeah, no, those are two wonderful questions, Avi. The first question I'll tackle is related to school-based health centers. And so school-based health centers, the interesting part is that in these districts, particularly like for Santa Fe, focusing on Native students, and in Socorro, and in Roswell, there were actually no school-based health centers that were in Santa Fe for these students, but also in Socorro and Roswell at the time that this grant was started were not present in those districts. But we know, as you said, that school-based health centers provide an incredible support to the programming that's very similar to Project Aware because it provides both behavioral health and physical health, overall health care to students and their families. And so having talked with, actually, interestingly, Nancy Rodriguez recently, who's the head of the School-Based Health Center Alliance, there's a very strong interest in finding ways to expand behavioral health services in SBHCs because most of the services that are often provided are non-behavioral health services in many SBHCs just as a result of the availability of clinical mental health staff. And even with that, many of the services that are available are not often available regularly. So there's a definite interest in embedding these specific type programs within school-based health centers and expanding those behavioral health services. In terms of sustainability, it's interesting you also mentioned that is at the heels of this SB3 initiative, which I know many of us at CBH are familiar with, is many of the school districts have been working closely with their SB3 area partners to discuss how funding through SBA3 could be leveraged to continue to support services such as this in schools. And if unavailable, if they weren't part of Project Aware, sort of how do they think about programming like this within schools in their local areas? Because as we know, schools are where youth spend 80% of their time and are often a community hub. Fortunately, I will say for these three school districts, each of them are continuing services or have plans to continue services at the end of this grant once the funding ends. Socorro is going to be leaning into, as I said, SB3 and other local funding. Santa Fe has numerous sorts of other funding through HUD and other mechanisms that they've been applying to. And Roswell actually just received the school-based health center grant to expand those services, and they're going to start embedding this work into their school-based health center. And so there's been, I can say, fortunately, we're not going to be pulling out this grant and people are going to be left with like, so what now? And so I'm very proud of that fact. Not that I did much about it, but it's actually really nice to know that this work is going to continue in one way, shape, or form. Any other questions? Thoughts?
I wanted to thank you so much. Great presentation. The data is incredible. And I would say you did a lot to ensure the sustainability by having all of this data and for the communities to see this impact that services are making. So just thank you so much. I know it's very hard to implement brand new things in schools that have their ways, which are completely reasonable. And, it's just very impactful, the work that you're doing.
Thank you, Dr. Altschul. And I will say that, I had the opportunity, as I said, to present this with Tyler in Washington at a conference. And I received some really positive feedback from, for example, the state of Nevada, who doesn't have a project aware initiative, but wants to utilize this sort of framework to expand services in their own state through state level funding. And so that was also really exciting to imagine that there's there's buy-in to this sort of model where peers and therapists and wraparound services are provided all within a school district. And that also the school district's voice and voice is also kind of present in that decision making. And also Deb's voice in the back of my head, like, don't screw this up. No. It's been a tremendous grant. All right. Anything else? Well, I guess if there's nothing else, I'm sure you have better things to do than stare at me. But thank you all for joining today, and I'll turn it over to Tiffany. It's been a pleasure.